Hello, my name is Uzer Khan, and I am an acute care surgeon at the Allegheny General Hospital in Pittsburgh, Pennsylvania. It is my honor to present to you this East Minute where I intend to briefly go over the recently published data from the INFECT project. This study is a trial conducted under the auspices of the INFECT project, which was designed to help better understand necrotizing fasciitis and soft tissue infections to improve therapies and improve mortality. Ultimately, the INFECT project prospectively enrolled from 5 Scandinavian hospitals and, as is relevant to the trial at hand, provides the largest cohort of streptococcal necrotizing soft tissue infection cases. Noting the lethality of type 2 monomicrobial necrotizing infections and the emergence of Streptococcus dysgalactiae as an emerging pathogen, this study aimed to identify the characteristics unique to streptococcal NSTIs and identify the impact on mortality of a variety of factors such as comorbidities, early clindamycin administration, early surgery, and the use of intravenous immunoglobulin. In summary, this was a multi-center, prospective observational cohort study including patients with clinically identified necrotizing soft tissue infections from 2013 to 2017. The beta hemolytic group A streptococcal cohort was identified by positive tissue or blood cultures that were positive within 48 hours of diagnosis. Then, these identified streptococcal NSTI cases were compared to a separate cohort of non-necrotizing cellulitis to help identify factors that predispose to an STI, as well as to polymicrobial or type 1 NSTIs. As can be expected from a multicenter trial of this sort, a variety of clinical parameters were collected, including measures of physiology, Lernick score, and preoperative findings, as well as the use of IVIG therapy. Multivariate logistic regression was conducted to identify predictors of mortality in group A streptococcal cases and to identify risk factors for the development of NSTI, as opposed to cellulitis. The project was ultimately able to enroll 409 patients, of which 126 had group A streptococcal infections and 27 had Streptococcus dysgalactiae infections. This came out to be just over a third of the cohort. Bacteremia and septic shock were more common in group A streptococcal infections, whereas a high number of comorbidities in patients were less commonly seen. When comparisons were made to the cellulitis group, it was noted that NSTI patients had an association with blunt trauma, absence of chronic wound or skin diseases, and a lower BMI, i.e., obesity was not specifically associated as a risk factor for NSTI over cellulitis. In corroboration with a recent review, the Lernick score was noted to have a low sensitivity. When compared to polymicrobial NSTI, group A streptococcal infections had fewer associated comorbidities, increased rates of septic shock, higher SOFA scores, and higher rates of bacteremia. When assessing for correlation with mortality, increasing age, male sex, the presence of septic shock, and non-administration of IVIG were all noted to be risk factors. In conclusion, and in summary, this is the largest prospectively enrolled cohort of necrotizing soft tissue infections. The authors note that group A streptococcal infections can cause an STI in previously healthy patients and without an obvious portal of entry. In addition, when compared with polymicrobial NSTIs, group A streptococcal infection is associated with higher rates of septic shock, organ failure, and bacteremia. Nevertheless, the authors related lower mortality overall for group A streptococcal infections, likely due to the better underlying health of these patients and the earlier surgical intervention that the study notes. They also reproduced the finding that the Lernick score has low sensitivity. Finally, the authors note the controversial nature of the use of IVIG as a therapy in the setting of NSTI. They present the improved outcomes with its use in group A streptococcal infections and contend that improved outcomes may be reproducible with IVIG if it is restricted to this cohort. This paper is worth reading in its entirety for its nuanced outcomes and discussions that are left out of this East Minute. Thank you all very much for your time.